मैं बाहर हूँ एक वोट नहीं करना चाहिए और सब
एवी एवी टीम नेक्स्ट लेक्चर लिस्ट में कौन सा आपके पास नेक्स्ट लेक्चर बताओ। ऑर्गन ट्रांसप्लांट पैनल भैया सुनो भैया फ्लोटिंग माइक चाहिए मुझे, फ्लोटिंग माइक 2 चाहिए यहाँ पे स्टेज पे करण हाँ कॉर्डलेस
यहाँ पे रखे हुए हैं,
दो रखिए ना, तो वहाँ पे आएगा एक टेबल वहाँ चला जाएगा। सर वहाँ पे टेबल मतलब वहाँ पे रख देंगे, ये ले यार 2 रखिए वहाँ पे, यहाँ पे रखो 2 चेयर और आएंगी ना अभी। हाँ हैं कितनी हो गई है? नहीं जोड़ देंगे वहाँ से जब चिनार की बात नहीं उनको बोला, उनको ये वाली चेयर अंदर चाहिए, उनको बोल दो ना, बोला अंदर बिलो पे बैठ के हेलो, हॉल कोऑर्डिनेटर्स, क्या हुआ? अमित चेयर कहाँ है बाकी? एक और चाहिए। 5 कितने हो गए अब? 10 लोग हैं यार, सिर्फ इसी सेशन में 10 हैं। टोटल कितने हैं अब? हाँ 9 चेयर है ना, तो 9 तो लगाओ, 9 तो लगाओ, एक तो बंदा खड़ा होएगा ना। एक तो खड़ा ही होगा ना हमेशा। ले यार फटाफट ले, देन वी स्टार्ट। सुनील, सुनील बाहर से किसी हॉल कोऑर्डिनेटर को बुलाओ, बोलो सेशन स्टार्ट कर रहे हैं, बाहर बोल देंगे, अनाउंस कर देंगे। करण, करण बाहर बोल दो सेशन स्टार्ट कर रहे हैं विन 5 मिनट्स। करा रहा हूँ, 3-4 मिनट में करा रहा हूँ सर। हाँ हाँ ना, पता लग गया, पता लग गया। तो फिर आप तो बेस्ट हो। हाँ हाँ, उनके जोड़ी साहब वाले के बाद में है आपका।
जोड़ी साहब वाले के बाद में बस उतना ही टाइम।
हाँ हाँ, वो भी आधे घंटे का है सेशन।
आधे घंटे का नहीं, 10 मिनट।
जोड़ी साहब वाला
जोड़ी साहब आपको क्या जरूरत है?
नाम आपका हुआ था अनाउंस? नहीं, कैंसिल नहीं किया, कैंसिल कोई नहीं किया। आपका नाम क्या है? हाँ ठीक है डॉक्टर विक्रम। रुको, आपको मैं दिलवाता हूँ। कौन कौन दो हैं? विक्रम सर, डॉक्टर विक्रम, कौन कौन है? आप और डॉक्टर सोम। वहाँ पे उसको रिंग कर दे रही, ऐसे लगा दे वहाँ पे, थोड़ा सा रिंग जैसे कर दे। So we would like to begin our next session. I believe all the speakers, all the chairperson and the panelists are here. This is a very important panel discussion on organ transplant. And I believe Gangaram Hospital has always been very actively involved in organ transplantation. All good? So we all know that Gangaram Hospital from the beginning has been involved in all kinds of transplant, and it was a mastermind of Dr. Manchanda to include this transplant session where we can keep on stage every possible organ which we can think of getting transplant done into a human body. And as you can see, there are so many people involved in this panel. And with the king of transplant surgery at Gangaram Hospital, Dr. Harsha Johri. So we have a very elite panel here. I would request everyone, if they have finished their lunch, they can just join in. We are starting in 1 minute. Dr. Johri. So first I will invite the panelists and then the moderator. So I would like to request Dr. Anita Ganga. Dr. Anita, please. Dr. Vipin Tyagi. Anita is ophthalmologist. Dr. Vipin Tyagi is main urologist here with us. Dr. Ushas Dheer, liver transplant surgeon. Dr. Sujay Shah, the most difficult heart transplant. Dr. Sujay Shah, can someone call Dr. Sujay Shah? Manas, can you call him? Karan, can you call Dr. Sujay Shah? He was there outside. Dr. Manas. Dr. Bhim Nanda. Dr. Manas, you have already heard, he's a hemato-oncologist for bone marrow transplant. Dr. Bhim Nanda was an active part in hand transplant. Dr. Kanav Anand, our pediatric nephrologist. Dr. Sudhir Chaddaji, one of the earliest person who was there with Dr. Johri to start the kidney transplant, one of the most successful transplant program across India. And we'll wait for Dr. Sujay Shah and none other than Dr. Harsha Johri. May I kindly invite you, sir, to start the proceeding of this transplant panel. बैक साइड रख दे डॉक्टर सुजय शाह आएंगे और कौन आ रहा है डॉक्टर अनिल अरोड़ा जी ही इज द मॉडरेटर आल्सो आ जाइए सर डॉक्टर सुजय शाह जी प्लीज इधर आ जाइए सर Dr. Anil Arora is our chief of gastroenterology and is involved in all liver transplant patients. Over to Dr. Harsha Johri.
Good afternoon, everyone.
Close the door.
See, most surgeons have very small brains. They work on spinal level. And after a meal like this, most of the blood is diverted to the stomach. Dr. Roman Datta also, please. Yeah. So most of the blood is diverted to the stomach. So the brain becomes a bit lethargic. So I'll try to make it a little more awake. Right? Now the question is, I've been given 30 minutes and less. And I've got to go through this wonderful panel of people. Now, Gangaram Hospital has been in the forefront of transplantation for the past almost 4 decades. And we are now known as the nursery of not only transplant surgery, but for all kinds of medicine. As Dr. Rana must have told you, 52 disciplines in which we have got postgraduate degrees. So people grow up here, they become stars, they become superstars, and then they go and shine in other places as well. And we glory in that fact. But transplantation, again, we have trained people in all kinds of transplantation, and they have gone to various shores beyond India, and they have done very well. So I'm just going to start now with the first. Tamsoma Jyotir Gamaya, lead kindly light. So we start with Anita Ji Gangar. She is a corneal transplant surgeon. I have just two questions from you. What are the causes and the load of corneal transplant, blindness, and what is the range of our work and what is the success? 2 minutes each, and then for questions from the audience.
So as we say, first of all, thank you for this opportunity to speak about it. In India, so corneal blindness is estimated around 1.1 to 1.3 million for bilaterally corneal blind people. And if we add unilateral blindness also to this, there would be further millions. Like around 9 millions of people are blind in India due to corneal blindness. So it is the most common cause. So commonly corneal blindness caused due to infections, traumas, any disease, degenerative disease like keratoconus, and diseases like, it can occur iatrogenic also after cataract surgery. So with the scenario of good surgeries now from the last decade, it has decreased, but definitely infections in rural areas still persist. So there is a very high load of corneal blindness in India. And unfortunately, every year it needs at least 1 to 2 lakh of transplants, which we are doing only around 25 to 30,000. So it's lack of corneas is the main reason, but there is a shortage and there is again burden of corneal blindness, which is adding up every year. And in our institutes, we are doing the corneal transplantations. We have our own eye bank, which is associated with Rotary Center. And here we are doing all type of corneal transplants like full thickness keratoplasties as well as the partial thickness keratoplasties, because as we have less corneas, we want to use every portion of it. So each layer, if the interior layer is involved, we transplant only that. And in any patient, if the posterior layer of cornea is involved, we transplant only the posterior layer. So that's how we use one cornea for at least 2-3 patients as per the need of the patient. So we are trying our best, but still we need to create further awareness for the donation of eyes so that we get the corneas and we transplant it more.
How do we get our students to get involved in cornea transplant? Because they are very easily led into other kinds of ophthalmology surgery. How do we promote this as a national program?
So at basic level, the main promotion is needed at the level of grassroots to increase the awareness. So every year we have fortnight, which is just held for this to create the awareness. In those, we create the various presentations, the awareness walk, and the various cultural programs to create the awareness. So that is the first step we need to do, and we can incorporate children in the, students in that.
Okay, from the eye to the hand, the coordination.
Thank you, sir.
India is the largest center for doing India is the largest country for doing hand transplants. Last count is, I think, almost 200. And cadavers is where you get your hands from. Every cadaver is a potential hand donor. Unfortunately, it is not translating into numbers. But you have done a whole lot of experience gained from other centers, and we have also done our own hand transplant. So what is your experience regarding the reluctance to donate, and what is the functional outcome once we have done the transplant?
As sir, you told that now India is the leading hand transplant center in the world. Taken together, the whole world, one side, and India is leading, as you said, more than 200 hand transplant in India. So the main problem is like public awareness, because if you see the other solid organ donations, like body is not disfiguring. But as soon as you explain the relatives that yes, we will be harvesting or we will be taking the hand at various levels, the relatives get, sir, like the body will be deformed. So what we do is we try to explain them that yes, we have processes made at all the levels. Once we harvest the upper limb at whatever level we required, we fit the processes to give the respect to the body. But still in our scenario, it's very difficult for relatives to accept that the body will be disfigured and patient will have a plastic hands at the time of cremation. So this is the main problem. Secondly, regarding function, like the hand, apart from the immunosuppression, which is like, the results are pretty good. because the tacrolimus or the immunosuppressants cause nerve regeneration better than the normal reimplant. People come with the people like who have amputation of the transplant better because nerve regeneration so implantation part which is reimplanted back to the same person, better prognosis function wise, sir.
Will you be able to have a grip? That is what is important.
So it's a level is there, but it's a little weak. At the wrist level or the mid forearm level, the function almost 100%.
So, and
Sir, and
for awareness.
Public awareness, sir, that yes, it will be dissipating. In a life of a bilateral amputee, sir, he can eat his food, he will eat an animal or just imagine. So it's saving transplant, sir, for that patient.
So now we have Gangaram Hospital is the leading center, and percentage of the credit should go to this young gentleman sitting over here because he brought I was to tell them they were not prepared to have dialysis. It was, sorry to say, it was to have, forget about transplant. He has managed to convince, we have done almost one of the largest centers in the country, if not beyond. Experience over the, how does pediatric transplant?
Thank you very much. So basically, as right from the young being and various things and beyond. And usually we, as per the secondary, also doing ABO incompatible kidney transplants. So if the blood group is not matching, because sometimes the blood becomes usually transplant. Then we have facilities like analysis where we can change the blood group, or you can say antibody titer can be reduced so that the kidney from the, and the risk of rejection is almost similar as to the so comes the different presentation is that you have to prepare a child for a transplant. It's not like you come to a transplant. So both of your kidney to the treatment to the because they are more prone to infection, and not the child. The family has to be if there's a infection again the infection is started. So the be activated and dialysis is out of metabolic load into the transplant. You have the kidney being transplanted most of the time are parents. You have to ensure that as the bigger vessel say moment the from the child's circulation. I should have a graph and put also for small post transplants or that so that also information compared to thanks take care of. We're not there in case once the so that it's not like just leave the child care of. Will require a lot of support because support also
that at the age of less than 5 he will growth sport growth makes it definitely grow.
So you referred people so that child will transfer the 5. So this the satisfaction that
he moved back. He is in marathon and he is international. What are the issues we handle? What is our experience?
Bone transplant is very different from transplant. Because the common is that type of surgery, it is not. You do is that you are to order stem cell transplant or to gene cell transplant. What do you have to look? Suppose I have some form of I have a infection. So what do you have from the patient himself? The high dose of chemotherapy, the high dose of therapy will kill the cancer and they put his own cells back. And this is a autologous stem cell transplant. So there's no surgery. You just take out the cells from the patient by a peripheral, like how you take a donation. Like other type transplant, so it's your own disease. So disease like thalassemia, you have chronic immunodeficiency, you have own cancer. So if you get your own stem cells, they have. So what you do is that you find a donor which preferably is a matched brother or sister, HLA match, not by group match, HLA match donor. We give this patient high dose of radiation, kill their bone marrow, and then put in a new graft from brother or sister, and this fixes the problem. It's not as easy as it sounds. It's quite intense. This patient has to be in a single room, which is HEPA-filtered, cannot meet anyone for 4 to 6 weeks. And there are a whole lot of infections that a normal human being never gets. They get all those, say, adenovirus, CMV, all sorts of rare infections. So transplant is either allogenic, autologous, and depending on the disease, either hematological, immune disease, or cancer, we use it for the patient.
Thank you. Now we will go from here to what we are going to be doing very shortly. And Dr. Roman Datta is going to tell us a bit about the patient selection and mode of which what is our preparedness and how can.
So thank you for
Mike.
the management clinical expertise which is available and all the allied branches which are available and all aligned and prepared for transplantation procedures at our center. As well, our hospital done a memorandum of understanding which is a high volume center from Hyderabad, and us during the first few surgeries and so that they can go and even free way. That is what we are doing, and lots of people from our hospital has also been trained as an observership in their facility, and they are all geared up and prepared to do the first lung transplant at our facility very soon. So from the clinical expertise From the side, and we have started our lung failure clinic, where we are identifying the patients who is suitable for lung transplantation in the near future. And whenever we get a patient with end-stage lung disease, then we refer the patient to our pulmonary department. They admit the patients and they evaluate for the suitability for lung transplantation as well as risk assessment.
Heart transplant. And then it so happened that while we started in Delhi and in Chennai together, the Chennai people were much more aggressive, and they were taking on borderline donors and borderline recipients. And I was a bit worried that this is such an expensive procedure, we should not be taking borderline hearts and borderline recipients. So there came a time when the Chennai group, it suddenly exploded, and that has gone to 100 patients a year, and we've lagged behind there. Second thing was that during this last 4-5 years, there were new medical treatments that came in. The medical treatments optimized a fair number of patients out of heart failure who were able to lead productive lives. And now we are again getting to see those patients who have had productive life for 4-5 years now failing those treatments and requiring transplant. This is a addition to a patient's quality life is actually a big thing. So whatever we did not do many patients in the beginning. It's a slightly more complicated work than living related, because there is limited time available in which you need to stop the heart in the donor, retrieve it, pack it, transfer it to our facility, implant it in the patient, and then get it working. So because that time is limited, you can't fly these organs from all around the country, and there's only local, regional transfers that you can achieve. So that is one big problem. Otherwise, we have not had a problem even after getting a 3-hour-long flight, 3.5-hour-long flight from Madurai for a very desperate patient. We did that, and we did not have any problem with
Green
that.
corridors set up by the police. They are very helpful. You can shoot across from the airport to the hospital in virtually no time. It goes faster than any VIP movement because they clear the roads in front of you very fast. And people have traveled in south also from one state to the other by road, and very good timings. So that's very good. Now I'm descending, you see, because when a cadaver is available, we go in all directions. You go from above downwards, and then we go to the liver. So Ushas, he is one of our sparkling and shining liver transplant surgeons. So I want to ask you, what is your current success rate what is life after transplant and what is the risk to the donor? Especially in India, we are doing a lot of live liver donations. So people don't talk much about the donor, but I think, the life of the donor is very important. So what is your current success rate and what is life after transplant for a patient and what is the risk to the donor?
So our current, we've, over the last decade, the success rate in liver transplants overall has improved, but our current success rate at our institution with a good one graft allograft survival is over 90%. And in fact, last year, I'd like to share, we've had over a 95% success rate. The 5% mortality that we have faced is because these patients have been extremely sick, like Dr. Shad was saying, borderline recipients. We get a fair share of our patients who are extremely sick, high MELD scores, and very sarcopenic by the time they say yes and accept that they are transplant candidates. We try to optimize these patients to the best we can. Some don't give us a window, but some give us a window. To sum up, we have achieved over last year 95% success rate in living donor liver transplantation and a close to 100% success rate in deceased donors, which we have done. Life after liver transplant, actually the liver transplant recipients require way less immunosuppression than the other solid organ transplants like kidney. So within 3 months, our patients, more than 90% of these patients are off steroids. So we have an early corticosteroid withdrawal protocol at Ganga Hospital. Within 90 days, most of all stop steroids, and they are on dual drug for first 2 years. And after 2 years, if they are doing well, they are on single tacrolimus-based immunosuppression. So within 3 months, most of them are back to their normal life, whether it is professional or social. There is a myth that they would be, enclosed in a room, or they won't be able to see relatives, they won't be able to go out. That's totally a myth. Most of these patients are going back professionally to their work, attending weddings, going to social occasions, whether it is temples or gurudwaras. They pretty much come back to what their life is. And in honor of these patients, in fact, a couple of years ago, under Sir's leadership, we had organized what is called Berok Zindagi, and we celebrated all these patients. And all of these patients performed. Some sang, some played guitar, and majority of did a ramp walk there. So it's very good. As far as risk to donor is concerned, at Gangaram Hospital, we are very, very careful about selecting our live donors. And we do not take any borderline live donor, and the overall risk rate that we tell the donors is less than 0.5%. Knock on the wood, we've had excellent donor outcomes at our institution, and we are proud of it. We, along with our hepatology team led by Dr. Arora, we don't compromise on any donor, whether it's a future liver remnant or any abnormal anatomy which may compromise donor safety. We have been very much sticking to our ethics.
Thank you very much. This is not part of the program, but Dr. Anil Arora has been spearheading a lot of the work for the immunology, for the care of the patients, for liver transplant. So I will ask him, what is your experience of the journey of transplantation, liver transplantation in Gangaram Hospital?
Yeah. I'm sure some of you who had been in Gangaram Hospital for many decades would recall the story. Dr. Ajay would recall when he was already in the management. I was a young hepatologist under Dr. Sama, who was the leading gastroenterologist at that time. Dr. Sama was incidentally the founder of gastroenterology. So we had a patient of Budd-Chiari syndrome with tense bulging ascites and number of collaterals and not passing urine. He required a liver transplantation. At that time in 1998, there was no liver transplantation which was being done in India. So as a young guy, as a young consultant, I was posted to go with them to send Cromwell Hospital in London to get a liver transplantation done. And this was an industrialist son, and we had a total money of around 2 crore Indian rupees, and we were told that that should be sufficient for liver transplant. And then once I got him admitted, he had a tense ascites. They will not drain him because they said, oh, we don't drain it, the ascites regularly to make him comfortable. He's waiting for his liver transplantation. The cost of, in 1998, sir, the cost of ultrasound in St. Cromwell Hospital was 700 British pounds, and the cost of the room stay was 2,000 pounds. So we exhausted all our money over the next 2 weeks. So since there was no hope of getting a cadaveric donor because we were outsiders for the British mainland, we had come from India. So we came back, and unfortunately, in spite of doing a TIPS procedure, we lost him. So that is what instigated us. That is what only propelled us to go in for our liver transplantation training. Fortunately, we had two young, bright surgeons from AIMS, Dr. Subhash Gupta and Arvind Soin, who had been in Indian cities trying to set up liver transplantation. So I was the first hepatologist who was sent to Birmingham by Subhash Gupta for training for liver transplantation. We came back, and thanks to our ever-encouraging team led by the management, especially Dr. Mahajan and Dr. Sama, we started doing liver transplantation. Being from hepatology, we had a huge clientele of patients with cirrhosis who needed transplantation. And then after Dr. Subhash Gupta, who had set up the preliminary program, we had Dr. Soin, who joined us from Apollo Hospital. And between three of us, we did around 10 consecutive transplantation. Now, there is a basic difference between liver and kidney transplantation. In kidney, you have to only attach an artery and a vein and a ureter. Liver is the most complex organism. It is almost 5 times the size of the kidney, and yet it has multiple inputs and multiple outputs. So technically, it is far more demanding. But logically, immunologically, it is far more stable than kidney. That is the basic difference. So if you are able to overcome the technical factors, liver transplantation is something, is a rebirth given to you. Whereas problems occur in renal transplantation because of long-term immunosuppression. So first 10 consecutive patients we lost. In fact, we as hepatologist team thought कि अगर patient ऊपर गया है in OT, so means ऊपर ही गया. But that was a learning phase. And hats off to our committed team, Dr. Sama, Dr. Mahajan, and the surgical team. We still persisted, and our 11th patient was a success. So I conducted the first national conference on liver transplantation held as it come of age in this very Indian Habitat Center in the basement. And it was the first time we had everybody around in 2004. And after that, it is a success story. India is the biggest hub for LDLT program in the world after Korea. We are the biggest training center all over the world. But as Dr. Ajay said, that we have been brewing distilleries, we have been maturing the saplings into the trees. So all our trained people, we have been exporting without imposing any tariffs like what Trump does to other cities. But fortunately, we have been able to establish a very good liver transplantation center. But problem is because of the constraints of the space, we have missed our stalwarts. But we have excellent trained people like Dr. Dheer and his team, and we are doing a good work. Thanks to you.
Thank you, Dr. Arora. Now from there to Dr. Sudhir Chadda, who's been with me for the past almost 3.5 decades. Transplantation, kidney transplantation in Gangaram Hospital was the vision of Dr. D.S. Rana, who was the first person to have the confidence to say that we will do transplant in a non-government institution in northern India. And I joined them very shortly after that. Then Dr. Bhalla came, then Sudhir joined, and we got going. Now, I would like Dr. Sudhir tell me about our journey over the last almost 4 decades. What you count as your achievements and what innovations we have put in there.
Thanks, sir, for inviting me, sir. As told by Dr. Johri, we started the program very early in the late 1980s. We were the first center in the country to start using external iliac artery as the main artery for the recipient. Before that, almost everybody was using internal iliac artery. I presented the series of 300 cases in UCCon 1993. And after that, we were using external iliac artery routine in all the cases. We started transplants with the catgut, using catgut for the anastomosis for the ureter, doing ureter cystostomy. Almost every 4th patient used to have urine leaks. I used to sit there with the patients, seeing urine coming in the catheter or in the drain. After say around 3 or 4 years, we shifted to Vicryl, and almost all the urine leaks stopped. We were the first center in the country to routinely use double J stents in the ureteral hysterectomy. Again, that helped us a lot. We were the first center in the country to accept diabetics and hepatitis B positive patients for the kidney transplantation. We have done roughly rate matches with the best. Our success rates in the first year roughly 98 to 99%, 5 years 70 to 80%, 10 years 50 to 60% patients are alive and doing very well.
Thank you. Innovations and achievements, but at the same time, you have the confidence to start doing laparoscopically the work, donor work, right? And now, confidence side, avoid taking all of the. Add to that, we also started on the ABO incompatible. Now, ABO incompatible is or high risk patients. The first few patients, you are as much on tenterhooks as everybody else. If you have a mistake over there and you have a acute rejection on the table, you have got problems. So it was really doing at least a week. Sustained effort over the years, and now we have come to now our robotic work. To ask you, recently you did some tele-robotic surgery, right? And we a scope for maybe.
Yeah, it is there. So we are in starting this way back in 90s. We have pioneer in all the things, and to become a comprehensive, we should avoid to the recipients and to have as low application. So obese patients, the robotic kidney transplant offer a very distinctly obese. They are either transplant in centers, and when we used to do a transplant, we used to encounter kidney transplant distinct advantages, and that's how we become. So we have 10 invasive surgery. Increase the ation of doing a recipient surgeries. As you say, right method, we are the biggest was taken in a laparoscopic way. So all minimizing technology, we are for doing the transplant and decreasing the morbidity, and as well as to the.
That is distinguished panel questions now. The distributors, if there's any questions, then ask. Yeah. Please from the audience, please.
Basically, the additional cost for robot. Significant cost difference.
For liver.
Success of liver transplant about 80 to 90%, 70% to up to 60% is the complex. All the organs, which I think most of the elite panel has already discussed, organs. Problem occur because of the continuing suppression. As Dr. Dheer very rightly, after 5 years you have minimal immunosuppression for the first and then subsequent for the first 5 years without the metabolic immunosuppression. Yes, we have experience. Because a lot of these patients have muscle and diabetic, which both the things, kidney and just about.
Very good. We have one of the largest of combined kidney transplant, whether it is a mind liver and a live liver and a live kidney, just in the patient 14 days. Dr. Ganga was saying, make another combined kidney transplant that we did. Is also here, nephrologist. 21 liters of urine to it. So the patient was very happy that he's making now almost years. So, and we've also done something very unique is that live donor liver and in our which is comparable to standard series on very analysis. And we're very proud to have a nephrology team to support the operative post. These patients get transplant patients because we have liver along with them very so immunosuppressed less, and if you do the transplant within 3 months organization, so it is possible. We do not do very well. We were do not stress we have most difficult scenario.
So if there are no questions, I will just. All cadavers are but unfortunately it takes a lot of it's a leap of faith also. It's moving. So I'll take the question by saying the national organ tissue so we are pushing at every meeting there should be combined commitment that people should make donor pledges, awareness, a lot of things. One of the things that's come out from our conversation here that in Gangaram Hospital, every single plant is what we define is a much more concerted meeting with the ministry and with the maybe for separate city. Hospital will be only plants of yeah. So, I will just say that the hospital in no way has ever touched down. We were the first institution in the country to be declared a center of excellence for transplantation. And it has just gone on and on and on, gone to other departments. We continue to be a center of excellence. Most important is, why do we do the transplant? To give a better quality of life. We are talking about giving life. I just want to say what Dr. Dheer said forward. Last year, the World Transplant Games in Germany, we had 50 those patients who were heart, lung, kidney, liver transplants came back with 63 gold medals. Our entire Olympic till now has never. And over 5,000 meters, squash, badminton, javelin, high jump, long jump, you name it. And the one who won gold medal was having a liver transplant and winning gold. So the quality of life is unimaginable. I have got at least 70 to 80 men who after transplants have become fathers of normal children. We have got women, at least 22 women, after transplants have become mothers. So this is the quality of life we want to give. Length of life nobody can guarantee. I can't guarantee my own. But quality of life. So it is all there to be done. So thank you very much for a patient hearing and a round of applause for our... Thank you.
लग गया
Good afternoon. Our next session brings a vascular surgery perspective to conditions frequently encountered in clinical practice. Dr. Ajay Yadav will discuss clinical insights, emphasizes early identification, referral, and involving management strategies that can significantly influence outcomes. The chairperson for this session is Dr. Sandeep Agarwal. Sir, I would like to request you to join us on stage.
Thank you very much. So I'll be talking about something that we all see in our practice, but fortunately the treatments are changing, and I think a lot of things have changed, and I'll try and go through some of it. So we start with the history of a case where a 57-year-old gentleman travels from Paris to Delhi, economy, window class, standard, what we like, complains of left calf pain, swelling on landing, has breathlessness by the time he reaches home, and is rushed to hospital with severe breathlessness. So he comes to our casualty with severe breathlessness. We get a quickly an echo done. Fortunately, we have a 24-hour duplex facility in the hospital, so within minutes we can get a duplex done for you for the lower limbs. So we had a left iliofemoral popliteal DVT, and an echo also had done at the same time showed massive RA-RB dilatation. So this is a classical sign of pulmonary embolism. So if we talk about this, this is classic economy class syndrome where one air passenger, especially because he's sitting in a constricted seat, a long flight, probably had a drink or two, it's dehydrated, develops deep vein thrombosis. So I think more important for elderly group of patients or for patients who have had previous history of DVT, they need to stretch and walk more regularly. So and probably an aisle seat is preferred. And always keep doing your calf muscle exercises. So keep moving your toes, wriggling your toes. And this is something that we forget. So air embolism, or I would say economy class syndrome because of air travel, is seen, and it is frequent. And mind you, if you go through the magazines which airlines provide, in last 5 or 6 pages, one page is dedicated to actually DVT prevention. We don't read that. We probably end up using just the advertisements part of it. So autopsy data from PGI also has corroborated that around 14% of all hospital deaths or sudden cardiac deaths, or that we attributed to, were actually VTE. So we take up this patient quickly into our cath lab, and we find that there's a massive DVT. So we have a special machine, which is an AI operated machine, a computer assisted device, where we can quickly put in, it basically go into the pulmonary artery. You can suck out the clot, you can see the amount of clot which comes out, and immediately the patient's saturation starts improving. That's how you collect clot. So huge amount of clots cleared from the pulmonary artery. There's immediate relief in breathlessness. Mind you, this is being done while the patient is awake. It's done under local anesthesia. The vital stabilizer, echo next day, the PSP is 35. So you can averted a major tragedy within minutes of patient reaching the hospital. So I think this is what is important, that pulmonary embolism no longer means death. It means that we can salvage this patient and give them their life back. And this is something which I'm going to reiterate today. So that's the kind of clot the patient had, huge clots in the pulmonary artery. And once we are able to suck them out, the patients immediately improve. The level of breathlessness or the cor pulmonale or the right heart pressure changes that they get with such severe PE actually absolutely disappear. So these are the usual symptoms of DVT, and I think we have all gone through these slides earlier and understood that pain in the legs, swelling, and probably pulmonary embolism is something that we dread, which is usually by dyspnea, severe chest pain, coughing, or even hemoptysis. If you go for examination, they have a low pulmonary artery pressures, they have a tachycardia, tachypnea. On echo, there are right heart strains, there are classical ECG changes, and I think we are all aware of this. But I think more important is, once you see any of these, how do we treat them, and where do we get them sorted? I think the aim today is, and I think all studies today have very clearly indicated that all clots in the body, wherever they are, whether it is deep vein thrombosis or whether it is pulmonary embolism, need to be taken out. And we have special devices. So I think I'll see if we can have some. So yeah. So this is a special suction machine. You can hear the voice, and it clears a clot like that. Within 3 minutes, you can probably clear the whole of femoral vein, another 5 minutes to clear the iliac vein, and in probably 10 minutes, you can clear up the whole of IVC. So you can clear up the whole iliofemoral system within 10 to 15 minutes, and that's life-saving. You don't need to do it under anesthesia. You can do it under just local anesthesia. So this is the main technology there. It's a computer-assisted system. It's got an AI which basically opens. There's a valve which opens when you're aspirating thrombus, but it closes as soon as you're aspirating blood. So imagine putting a tube, which is practically the thickness of my finger, into your veins, but the problem is it's going to suck blood. And if it sucks blood, that kind of blood is probably suck around maybe 500 ml of blood in a minute. But this computer-assisted system actually blocks as soon as you're sucking blood, but will only suck when you are aspirating clot. And that's the AI part of it, which makes it work. So the actual blood loss reduces by 70%. So it is designed for clot detection. And this is how you see it. You see that valve opening in milliseconds for just sucking the clot. And as soon as you get water or saline or blood, it stops sucking at all. So you can reduce the blood loss by 18 times and makes the patient safe. So another case, another young lady, army officer posted at high altitude, comes back with massive swelling, and usually in high altitude thrombosis. We managed with a low molecular heparin. The symptoms didn't improve, so came to us. So we did the similar device. So this is punctured around the knee area. You get a catheter in. You start sucking the catheter through the catheter. That's a penumbra catheter again. And once you start doing it, you see that the clots have improved. You can remove more and more clots through it. You make multiple passes. If you look at that slide, you can see the catheter actually engaging those clots and sucking it. You can see the clot moving with the catheter. And the multiple passes like this, you can actually remove most of the clots. And within 5 minutes, you can get a clear vein. The patient actually had something called May-Thurner syndrome, where there's an occlusion of the left iliac vein by the artery. We can do a balloon plasty, put a stent there if needed. And that's the final result, a clean vein. So imagine an army officer with an obstructed system. She can't go back to active duty. But with this, she can do any kind of activity she wants. So that's the kind of clots we removed. And this can be done even for iliac system, for IVC. So these are the new cath labs we have in Ganga Hospital, which we fortunately can do such complex cases. So in the end, I would say, is DVT still there? And I think the myth was that India doesn't have DVT patients, but that's wrong. We are probably underreporting. We are not catching them as frequently as we should. The hospitals need to be more careful. I think as GPs or as physicians, we need to be more careful on understanding that blood clots can be dangerous, and we need to treat them as much as we can. They tend to have an iceberg effect. We see much or maybe treat much less, but we miss out on a lot more. Please be more vigilant in getting a good Doppler done, getting an echo done, or a CT pulmonary angiography to diagnose these things, and we get them treated early. So our take-home message would be a early thrombus removal strategies which is working. We need to have an open vein hypothesis, so remove clots but reduce blood loss. And computer-assisted venous thrombectomy is probably the new thing to go for. Thank you very much.
Thank you, Dr. Ajay, very beautifully shown both the cases. The DVT is a very dreaded situation. Sometimes it is mistaken as a massive heart attack. And as Dr. Ajay told, I remember 30 years back when I started my practice, our first slide used to be in our talk, the DVT. Is it a myth or reality? Everybody thought that it is a disease of the Western country. But daily we see at our center, in Gangaram Hospital, 8 to 10 new cases. Every patient is not put for these fancy treatments. Many patients, they are put on the anticoagulation, but when the patient, they are having the massive DVT, just not for today, for tomorrow, to preserve the wells of the deep veins, we do this. And obviously, if the patient is having acute P, then too it is a life-saving procedure. Dr. Ajay, I just want to know, everybody is now talking about artificial intelligence, this way, that way, assisted. What the artificial intelligence can do the harm of a professional, professionally, physically, financially? What do you think in the future?
Doctors will probably end up using a lot of these technologies to help diagnose patient better. We're going to be missing less diseases too. It will probably help us in making better drugs or getting drugs back from discovery to market quicker, hopefully. Treatment-wise, I think they will probably dictate at some time, but right now I think doctors still need to make their own clinical decisions.
Okay. Thank you. Any question from the house? Yes, one by one, please.
Sorry, sir? So I think thrombolysis has its own side effect because obviously you are giving thrombolytics, so the chances of bleeding are much higher. In clot suction, you are able to remove the bulk of the clot and you're getting a clean passage. But if you find that there are small clots in the smaller veins, you can give thrombolysis, but the duration of thrombolysis will decrease because without clot suction, the thrombolysis would have continued for at least 3 to 4 days. Then the risk of bleeding would be there for 3 to 4 days. Whereas in this, within 24 hours, all the clot is gone. Sir. So I think the treatment starts obviously with you because the correctly diagnosed and correctly timed diabetic treatment is what is important. So if you are able to diagnose and treat diabetes properly and also counsel the patient to look at the feet every day. And I think this is important because the patient as well as the family needs to understand that looking at the feet is more important than looking at their own face. And this is where we are lost. So treating them early, treating them well, and referring to a person who can actually manage these diabetic feet ulcers is the treatment.
In form of discoloration of the toes?
Yes, sir. So then they get a Doppler done, and then maybe we do a angioplasty or surgery to improve the blood supply of the feet. Thank you very much, sir.
See, what you presented was acute DVT. Somebody reaches Ganga, bed mile na mile, you don't know.
इनके लिए सबके लिए है सर. इनके लिए हमेशा मिलेगा.
But the question is, we end up with lot of cases which are chronic or acute and chronic. ठीक है? अब what do you do with those, especially even in pulmonary embolism? I recently came across, I got a call from the US कि भाई there is a relative उसको massive pulmonary embolism था और अभी suddenly patient desaturate कर दिया, उसको घर भेज दिया गया था. The idea is how do you manage these chronic cases? Can you do something besides anticoagulant?
Yes, sir.
Dr. Saab, I think your question is needs a demanding answer, which will take a long time, है ना? And because of the shortage of the time, I would like to request Dr. Ajay, है ना?
Thank you very much, sir. But this will work both in acute and subacute cases. It does work. Even in subacute cases, you can remove the clots. Yes, sir. Thank you very much.
Thank you. Thank you, Ajay.
As we move on to the next session, there's a very interesting question. Do miracles happen in oncology? Do they really happen? Let's see. Cancer care through the years.